We're live. Great, thank you.
You ready?
Sure, give it a minute.
No, it's 7 o'clock. We're going to start. It's 7 a.m., so let's go ahead and get started with Grand Rounds today. We have two great speakers from the faculty, Dr. Iorio and Dr. Aftab. First up is going to be Dr. Matt Iorio. He's a professor in the Division of Plastic and Reconstructive Surgery. By way of his background, he did his undergraduate degree at the University of Chicago and then went to Georgetown, where he spent many years first doing medical school, and then he did his plastics and reconstructive surgery residency before he then came out to the Pacific Northwest, where he did hand and microvascular surgery fellowship training at the University of Washington. Then he went back to the East Coast, where he was an instructor and assistant professor at Harvard from 2014 to 2017. And then he came to the University of Colorado in 2018 as an associate professor, and then rose through the academic ranks up to be professor in 2023. He won the Teacher of the Year Award in the Division of Plastic Surgery in 2022, and then just 2 months ago was given the Impact Award at the UCH Annual Medical Staff Dinner. He's the co-director of the wound care program here. He's an associate editor of several journals. He's on the editorial board of some additional journals, has 134 peer-reviewed publications and 23 book chapters. And today he's going to talk about the orthoplastic surgery program and teach us about nerve and osseointegration surgery. Thanks, Dr. Iorio.
Sure, perfect. Thank you for having me this morning. I've got 7:02. That computer says 6:55 for some weird reason, but I will do my best to stay on time for everybody this morning. I know we've got a lot going on. So what we're going to talk about is just some of the collaboration and some of the things that we're doing within our orthoplastics program, specifically some of the nerve programs, as well as osseointegration. So my disclosures. All right, so from a limb preservation standpoint, we've talked about this orthoplastic program. That's something new within the University of Colorado. The idea is essentially the combined management of patients when they first present to the trauma base. So combined management with vascular surgery, orthopedic surgery, plastic surgery, to look at the patient holistically and say, what can we do? What can we provide as the best functional outcome for this patient? So we've gotten support from the hospital. I think this is a great program that we're starting to see improvement in some of our metrics and some of our patients. The idea behind it was based widely on somebody called Marko Godina. Marko Godina was a famous surgeon from Slovenia who was one of the first surgeons to look at reconstruction of the lower extremities, specifically following major trauma, where he was able to say there needs to be better time management and better efficiency of a lot of these cases, where patients not uncommonly would have a lower extremity trauma, open fracture, 2 months, 3 months go by, and then they would present for reconstruction. For any of you that have been in those cases, you know the amount of granulation tissue, fibrosis, induration, et cetera, really limits, I think, the success of those cases and how successful you can be in those circumstances. He was able to show, though, that treating these patients early demonstrated improved fracture healing, decreased infection rates overall. So there's been some discussion more recently where people say, well, yes, that's all well and good back in the 1980s, but given the fact that we have a VAC now, right? Can't we just temporize these things? Can't we just VAC these things for weeks and weeks and ends? No, not really. So our group actually looked at this and said, all right, let's look at specifically the time from fixation to flap coverage as compared to the time from injury to flap coverage. The idea being we want to dive in a little bit deeper to look at what are our hardware infection rates, what are our removal rates, osteomyelitis, things like that. So we were able to use a large database of about 800 patients and show that the Godina principles, quote unquote, are still maintained in terms of being able to get to these patients early or within the first 3 days would be optimal. Beyond 7 days, we start to see a huge uptick. You can see here on the chart, every gray band on this histogram here is essentially a metric beyond 7 days. So surgical site infections, osteomyelitis, operative revisions, hardware removal, all these things are increased by delays in time. And so the orthoplastic surgery team then's goal is to get these trauma patients managed quickly, efficiently, and with the most function that they can. So this is kind of typical for what we would see. This is a patient who was out in the mountains somewhere, had a big fracture. So we got called by somebody out in the mountains who says, I don't know, maybe I'm going to amputate. I'm not entirely sure what to do. He says, send it to us. So we'll take a look. So you can see here, we've got the hardware stabilized, but a big soft tissue defect. So we're going to take him to the operating room and we're going to do a super fascial or super thin ALT, which is our flap of choice. And you can see, I would argue that that's a pretty good reconstruction of a leg. The problem that we see following these reconstructions, so we can tap ourselves on the back to say, hey, I really like these ALTs, these are great, I agree. The big problem that we see though is pain remains a big limiting factor. This is one of the main things that's gonna hold back our function. It's gonna hold back our prosthetic use. People that aren't able to ambulate are gonna decondition. We know that patients that have a below knee amputation have about a 30% increase in metabolic demands, almost upwards of 60 to 70% for an above knee amputation, right? So we know that's why there's a big mortality following amputation because of cardiovascular deconditioning and that need to get up and kind of ambulate. The problem being that if over 70% of patients that have an extremity amputation have pain, how are we going to manage that? And so a big part of this program then, while we're seeing all this trauma on the front end, is to manage the back end of this pain and to say, how can we make these patients more functional, give them more independence, more freedom for their day-to-day? So the biggest things I would say when you're seeing patients that are in chronic pain, you need to differentiate and document, is this recurrent pain? Is this persistent pain? Or is this new pain? i.e., you've had multiple surgeries, you've had multiple interventions. Has it changed? Has it gotten better? Has it gotten worse? Has it moved up your leg or down your arm? How is the pain changing? Can I modify with local techniques like blocks and things like that? Those are patients that we more often than not are going to be able to intervene on. So the strategies then for pain management are around two concepts. So you'll hear these all the time, this TMR and then RPNI. So TMR and RPNI were developed as kind of our two mainstays for nerve reconstruction to say we need to give the nerve something to do. The analogy we give the patients are, if you've got an extension cord that's plugged into one wall and plugged into your TV or something on the other side, and you cut it mid-substance with the lawnmower, it's still a hot end, right? It's still sparking. It's still connected proximally to that cell body. And so it's still able to give aberrant feedback. And if it doesn't have somewhere to go to complete that loop, it's hard to reduce pain. TMR essentially is transferring that large injured segment of nerve here into a recipient, what we call a motor target. Essentially, so if that sensory nerve can travel back down the motor pathway, it's essentially going to ablate itself, so to speak, because that muscle doesn't have any sensory organelles to give feedback and essentially shuts down the circuit. Same thing for RPNI, regenerative peripheral nerve interface. We're going to take a small piece of muscle that's essentially a denervated piece of muscle and allow that nerve to regrow into it, reinnervate, and essentially shut itself down. The interesting thing about TMR is that this was initially described for prosthetic control, meaning the myoelectrics that we have to give patients more independence. We were doing these nerve transfers at the brachial plexus, so through the pec, through the deltoid, through the lat. And the first study that came out with about 26 patients came back and said, yeah, you know, the myoelectrics all neat and stuff, but BT dubs, I don't have pain anymore. And for a lot of these patients, that was a bigger win. And so the 93% of those patients actually showed up and kind of serendipitously said, I'm not in pain anymore. I actually feel a lot better. And so we started to see TMR not just as a nerve transfer, we still utilize it as such, but something dedicated or specific for pain control or operative relief as it pertains to kind of extremity trauma. Our orthoplastic group has written a few papers on this and kind of described some of the techniques and some of the outcomes. Essentially, when we're doing it from a technical standpoint, we're taking those sensory donors, identifying a motor target through nerve stimulation. So if there's a small branch to a neighboring muscle, residual muscle, one that we would say a lot of the time, you know, if we're in the lower extremity, we're working on the tibial nerve, we're working for sural nerves, toe flexors, things like that as your motor targets. But the thing to keep in mind is Neither of these are going to exist in a vacuum, right? They're both going to help each other. And so a lot of us would say that RPNI versus TMR is not an either or, it's more of all of the above, meaning that when I do my TMR, I do elevate the muscle around it so that I insulate my coaptations. So if there's any sprouting from my coaptation, I can capture them by that denervated muscle. Also, if I've got to come back and revise them, I'm better able to insulate those things out. And so what I would want you to hear is that sometimes I think these get a little bit polarized, where we will say, oh, I really like RPNI, I really like TMR. I'd say in the reality, for the majority of us who are doing these operations, it's more of a blended operation. We're going to do a little bit of TMR and a little bit of RPNI as based upon what nerve donors are available. So a lot of the data that has come out has shown that both TMR and RPNI are productive in terms of pain control and improvement. If we can intervene on those patients acutely, so at the time of injury, at the time of amputation, before pain gets entrenched and corticated, we're going to have better outcomes. I think the biggest thing to talk to your patients about, if you don't already, are what are your expectations, right? And so we spend a lot of time in the pre-op to say, where do you want to be afterwards? And we're very careful to never, ever tell the patient you're going to be 0 out of 10, right? You might be in a 9 or 10 today, and if I can get you to a 2 or a 3, that's a great win, right? That's high fives all around. And so the idea is if I can get you to a 4 to 5 point reduction, that's going to be a win. So improvement, not elimination of pain. We still do this though for myoelectric control. The neat thing that's come along is that as the technology of these myoelectrics has improved and the battery packs have become lighter and lighter, they're actually more accepted by patients. And so patients are able to use these and ensure additional function. So for the upper extremity, as an example, if we were to do, say, a transhumeral level amputation, what we're trying to do is actually recapitulate some of that innate function by taking known nerve donors and putting them into expendable recipients. So for the upper arm, for a myoelectric, we're going to transfer the median nerve into musculocutaneous branches, specifically the biceps, for the hand open phase. Radial to triceps nerve. So we're going to take all that and bring it into our main motor for triceps. So those are going to be our hand close. And then ulnar to musculocutaneous, the other branch, brachialis, it's going to give us some more of our fine motor on these myoelectrics. And I'll show you what that means in just a second here. So this is a patient I had with Dr. Grayson. Like I said, with our orthoplastics group. So this is a young lady who had a basal cell carcinoma, big involvement and needs shoulder disarticulation. And we say, well, let's try to maximize function. So what you can see here is on the left bottom here is the brachial plexus, all dissected out with branches. And then we're going to do a bunch of transfers. So like I said, we're going to transfer musculocutaneous into the pectoralis major, median and ulnar nerves into the sternal heads of P major, and then the radial nerve into the thoracodorsal. So depending upon what the level of the amputation is, hand-based, forearm, transhumeral, shoulder, forequarter, we're going to have different or varied targets. So this is a patient of mine that underwent a revision TMR from an outside hospital. You can see for his battery pack is super small. Let's see if I can, there we go. So this is his function. He's about, I think he was about 6 months out from surgery. So he's just learning how to control this thing. But you can see he can open, he can grip, he can move his thumb, he can move his fingers. And he's actually an interesting guy. He's a blast from the military. So he's got bilateral AKs as well. So his only good arm is his left one. But now his right hand, I would argue, is pretty functional. So yeah, the myoelectrics, I think, are a big improvement in what we're able to offer to patients now. The next problem that we're going to talk about, so I said we're going to talk about a couple of concepts within the world of orthoplastics and what we do for extremity trauma. The other part of this is osseointegration. And so soft tissue instability following these extremity trauma patients is also a big problem. Because whenever we're doing this, we want to salvage and preserve length, right? If the difference between a metabolic demand of a BK is 30-something versus an AK of 60%, and your 5-year mortality in your diabetic population is going to be somewhere in the 80th percentiles. We want to do everything we can to keep these extremities attached, right? But in many patients that have had burns and multiple traumas, it's going to be difficult to get them into a workable prosthetic. And so a good prosthetic fit requires stable and supple skin, which if they've had a burn or something like that may not be possible. Multiple studies have shown that the vast majority of patients who wear a prosthetic, especially a lower extremity prosthetic, get blistering and recurrent wound formation. That again, every time there's a blister, you've got to be out of your leg, you've got to wait until it heals. And so that means maybe we're going to cancel that vacation, or we're going to cancel that hike or that other trip or something that you're looking forward to. So just another kind of hit as far as function goes. So osseointegration, and the idea is it can prevent some of that instability by providing a direct skeletal attachment of the prosthetic. It's a titanium prosthetic, so it's going to have some bony ingrowth. A lot of this data we won't necessarily get into for just this quick 30-minute talk today, but this is born out of periodontal medicine. And so for any of you that have ever lost a tooth that had to get the little implant around your into your mandible there, you know that your gum tissue functions fantastically by preventing influx of bacteria down to that integration site, and can actually be a stable reconstruction. The problem is, and maybe this is very obvious, the skin of your leg is not the same as the mucosa in your mouth. And so this is what we've struggled with for the past 30 years, is identifying a skin penetration site that's going to give the same type of host response and potential protection that we would see in the mouth. The idea being, though, that osseointegration is going to give you better suspension, i.e. greater ease of use, reduced energy, and an overall better function. These are the main implants that we use. Here at UCH, we actually use a lot of the one in the middle. We use a little bit of the one on the far right. We don't really use anymore the one on the far left, but these are like anything else in medicine, especially orthopedic surgery, constantly changing implants. But just to give you an idea of how we cement and stabilize these, the next generation of implants actually have electrode or small leads that are coming off of them that we can implant directly into the muscle that further integrates with the myoelectric. So that's going to be a really neat advance. The other thing to keep in mind, and how this dovetails with what we were talking about for TMR, osseointegration is interesting because it's anchored to the bone. It does give you what's called osseoperception. So patients, even with a high AK, are now able to walk on gravel, walk on various substrates, and say, I can still maintain my balance. I'm still getting feedback from what I'm stepping on, and I'm able to be more functional on different terrain. The one thing to keep in mind, or what we describe to patients, are you want to make sure that you do your TMR before your osseointegration. Otherwise, it kind of turns the leg into a little bit of a tuning fork in terms of the increase in severity of vibratory pain. So this is a patient here. So on the far left, you can see that this is a very high AK. We're right up here into the inguinal crease there. You can see we've got unstable scar formation. And so to get this guy into a stable prosthetic at this level, most of us that have seen this would say, no, not really. So what we do is we open up, we widely resect the underlying tissue, so almost kind of guillotine right at that coaptation site, so there's not a lot of distal tissue that's pistoning or moving. And then we're going to do our stable implant through that skin penetration site up there. So there you can see him well healed. And again, you can see how high up that above knee amputation site is. So again, really, I think impactful and beneficial for those that would otherwise be considered too short or too limited to have a good prosthetic. The last thing then we'll talk about for osseointegration, a big part of where plastic surgery comes into this, is a lot of the problems that we see are related to infection at the skin penetration site. So essentially where that metal is coming out into the world, as you would imagine. So if there's a lot of pistoning, mobility, or motion through that site, it's going to drag bacteria back and forth. And so the goal behind this is to create a very almost fibrous reconstruction, something that has minimal compliance through that area. So we're going to remove as much subcutaneous tissue and muscle. As far as which patients can we do this in safely, or who do we want to do this in, the main two patient populations that are going to give us a little bit of trouble are going to be especially vasculopaths One, because you're not going to have enough blood supply to actually have a host response to have ongoing infection mitigation. Those are going to be a higher risk for infection, as well as if there's not enough blood supply to actually promote bony ingrowth into the implant, that's going to be a problem. But you can see these issues of distal redundancy and kind of pisting of skin, as you can tell, as it drapes over the implant. And so there's about 5 or 6 institutions in the United States that are doing these days. We're a big one. One of the other largest ones is Walter Reed back east. And so we actually trade a lot of patients back and forth because as a patient's body changes, you know, you can imagine following trauma 6 months or a year, they've gained weight, they've lost weight, things have changed. And so we see this soft tissue instability a lot, and that's where we spend a lot of our time. So here's another patient that had an above knee amputation. Very unstable soft tissue. You can see there's a lot of soft tissue on this thigh to get rid of. And so we're going to have a big wide excision. Like I said, we're going to actually cut away all this muscle or kind of guillotine it flush with the bone. We're going to resect subcutaneous tissue at the scarpal level to create as thin as we can, and then actually have some excision of tissue on the backside to kind of cone in that leg to, again, get it as tight as we can. So here's a patient example. I think it's actually another patient of Dr. Grayson's. So this young lady was in a car fire. These are her below knee amputation sites. You can see some kind of very thin skin, lots of skin grafting over bone there, unstable. So this young lady had difficulty with stable prosthetics, the amount of time it would take her to don and doff. You can imagine if this young lady wakes up in the middle of the night and needs to get up and go to the bathroom, go to the front door, to put on the sleeves, the liner, the prosthetic, and then repeat it on both sides, was usually about 15, 20 minutes for her. So instead, she underwent osseointegration here. You can see where we've actually got the early result. Here's how she looks when she's healed. So like I said, before we did this procedure, it took her maybe about 15, 20 minutes to don and doff. This first one takes her just a second. She kind of gets the hang of it by the time she gets to the second one, but you can see it takes her just minutes to get her legs on. And you can see she's got burn on her hands there as well. Yep, and then she's ready to go. And there she goes down the hall. So with that osteoperception, the speed that these patients can get their implants on, the increased functional independence that they have, being able to move around, especially those of them that maybe have limited other people at their house or live by themselves. This is a huge win as far as it goes for kind of functional independence. And so, like I said, you can see her big smile, but a lot quicker, a lot easier. And the other thing is, from a prosthetist standpoint, we don't worry about blistering anymore. We don't worry about the prosthetic rubbing through the skin graft or anything like that. All right, so in conclusion, orthoplastic surgery, I think, encompasses a lot of things. One of the biggest things that we're talking about is the efficient management of extremity trauma to maximize function, and through that, minimize pain and allow patients to return to as many of their kind of independent activities or their daily activities as possible. By including reconstruction of the nerve when we do these operations, so TMR, RPNI, we're going to try to mitigate pain at the beginning. We're also going to adjust or try to help patients that are in chronic pain that have had injuries for multiple years. TMR, RPNI, like I said, I think are a good option that typically work together to reduce some of this pain, and osseointegration is sort of the next wave of how can we get these patients more functional without necessarily having to further shorten limbs, reduce activities, or kind of otherwise allow patients to return to the things that they want to do, especially when there are soft tissue problems like prior burns, skin grafts, and large weight changes, things like that. And that's all I have for you this morning.
Questions. Let me start by asking the first one. I'm thinking back to my own residency where Dr. Rutherford used to constantly talk about how much increase there was in energy expenditure for someone to ambulate with a prosthetic. Have you guys looked at the effects before and after your osseointegration procedure as to what the energy expenditure was with a regular prosthetic versus the new one?
Mhm. They definitely are. So a big part of our research now is essentially in the PM&R space. So looking at the change in gait, looking at, can I put you on gravel? Can I put you on grass? For most people that especially have above knee amputations, that's very difficult. But a big part of that too is looking at the energy expenditure. You can look at that young lady there, and you can see how much easier it is for her to get her legs on and start moving around. Part of the differential though for the energy expenditure is even the technology in these legs is continuing to improve. And so the balance on the leg, for an above knee that kicks out the bottom part to keep up with your gait, so you don't have to use your body to kind of throw that momentum forward, has been a big change. And so I couldn't tell you what the reduction is off, but we think it's by several order of magnitude probably. So I think it's going to be fantastic as that research comes out.
You guys hired specifically a PM&R specialist to integrate into this program. Give people her name.
Danielle Melton has been
in
fantastic.
case they need to reference with her. Any other questions from the audience? Max.
Tremendous work. Just real quick. For referrals for either of these procedures, what's the process, how and when?
Mm-hmm. So we still have our nurse navigators. So Lindsay Hedges and Stephanie Boyd are kind of the two prongs to get into the program. The biggest part of this is when we're talking to patients about osseointegration, the reasons are why, what's going on with you. So the majority of patients that we're seeing are, the wounded warrior population that's coming over with multiple skin grafts, patients that have had massive fluctuations in weight, especially following amputation. They've gained 50, 60, 70 pounds, something like that. And a normal prosthetic doesn't fit. So I think a lot of the referrals that are coming in through the PTOT, PM&R pathways where prosthetists are saying, hey, I just can't get this patient into a stable prosthesis. From our other colleagues, though, the things that we're seeing there, if you're confronted with a patient that is otherwise healthy, meaning, not a heavy smoker, not a severe vascular path, maybe plus minus for your population. But if you see those and you say, hey, the only way I could get this envelope stable is to go above the joint, then, I think it's always worth a discussion. We've done this operation in patients that are, in the 20s. We've done this operation in the 50s and 60s. And so there's not as much of a strict age criteria in as much as, what are the functional limitations and what are you kind of shooting for?
Another question. So I have a hard time believing that you don't have an infection rate of 100%. Why is it that you don't have 100% infection rate?
So it's a lot of what we've done to the skin penetration site, meaning that when this operation first came out, the infection rate, you're right, was probably in the 60s to 70s. Because what was happening was we were just putting this implant in and allowing the soft tissue to piston back and forth. And so now when we do this, we spend a lot of time resecting the tissue around the skin penetration site. We bring it down to almost a skin graft thickness, so just very, very, very thin. And we pot it or secure it directly to the periosteum on the bone and try to secure it. But you're right, if that doesn't heal right and we get pistoning or instability, those are the ones that we have to revise.
Why does that work?
I don't know. There's so much. There are people out there that are even radiating these things to try to incorporate fibrosis. The problem is it pushes, I think, the hands too far to the opposite side where, again, if there's not great vascularity for a good host response, we have trouble. And the thing is that because of the way the implants are made now, if I can get early healing or bony ingrowth, essentially it seals itself off. So there's not essentially like a little tunnel or a pinhole where it can go back into the canal. It's those that don't heal correctly into the bone that kind of create chronic problems. Of course, thank you.
All right, we'll switch gears a little bit. And Dr. Aftab, most of you all know, is an associate professor in the Division of Cardiothoracic Surgery here at the University of Colorado. By background, he went to the King Edward Medical University in Lahore, Pakistan, before doing a general surgery residency at Hofstra North Shore LIJ School of Medicine, in finishing that in 2011, before he then went on to do his cardiothoracic surgery fellowship at the DeBakey Department of Surgery in the Texas Heart Institute at Baylor College of Medicine. where he finished in 2014. He then went up to Cleveland, where he was a staff surgeon and a clinical associate in the Advanced Aortic and Endovascular Surgery program before he came here in 2016 as an assistant professor. He was promoted to associate professor in 2022. He's on the editorial board for the Journal of Thoracic Diseases. He has had R21 NIH funding for immunoparalysis and acute kidney injury in the cardiac surgery population, has 100 peer-reviewed publication and 14 book chapters, and today he's going to talk to us about brain protection. Thanks, Dr. Aftab.
Thanks, Dr. McIntyre, for a very generous introduction. It's a great pleasure and honor for me to be here. For the next 20 minutes or so, I will talk about the strategies of brain protection. And I have no relevant disclosures, except that I grew up using the integrated cerebral perfusion, which is a technique to perfuse the brain directly into the brain arch branches, using both innominate and axillary artery cannulation. I learned how to use the retrograde cerebral protection at the University of Colorado. I love both of those techniques. Both have a role, but clearly cold temperature is good, but not good enough. It needs some adjuncts. This is the outline of our talk for next 20 minutes. We all know that stroke remains a significant life-altering event in patients who undergo hemi-arch or total arch replacement. The incidence of stroke varies somewhere between 3 to 11%, and the highest being in patients who undergo total arch replacement or acute type aortic dissections. So it's very important for us as a cardiac surgeons to optimize the cerebral perfusion, as well as minimize the risk of embolic stroke in these patients. Hypothermia with or without cerebral perfusion and neurophysiological intraoperative monitorings, as well as from pharmacological adjuncts, are the mainstay of neurological protection in aortic surgery. Very early experience with aortic surgery was described by Dr. Cooley and Dr. Michael DeBakey in 1951, where they tried to perform the aneurysmorrhaphy or resection of aneurysm with ligation of the branches and cellophane wrapping. Unfortunately, it did not work. Subsequently, 68 years ago almost, the first successful resection of aortic arch aneurysm was again described by Dr. DeBakey and Dr. Cooley together. And 5 years later, the same group presented their early experience of 52 cases with a proximal aortic arch replacement. And the operative mortality was significant at that time. As we were learning how to perform these procedures, was as high as 42%, which was very humbling. 6 years later, Dr. Cooley and his associate, including Grady Hallman, described their experience with 4 cases of total arch replacements. You could see these are formidable procedures. At that time, these procedures were performed with normothermia. All patients survived the surgery. 1 patient sustained a permanent stroke, and 1 patient had transient neurological deficit. I was impressed to see that 68 years ago, they were still using, and they learned how to and described how to use the integrated cerebral perfusion by placing catheters in both innominate and left common carotid arteries, and even placing catheters in subclavian artery. We should know the history of our own department. Henry Swan was the first full-time faculty here in the Department of Surgery at the University of Colorado. And from 1950 to 1961, he performed 600 open and closed cardiac surgical procedures with topical hypothermia. It's amazing that Henry Swan met with Dr. Bigelow, and then he learned his dog experiments, how he has been using hypothermia, and they had a challenge in ventricular fibrillation. And he developed a technique where he could induce hyperventilation to minimize the acidosis, perfuse the heart with neostigmine to minimize the fibrillation, and use the IV glucose to perform successful topical hypothermia and open cardiac procedures. The main limitation with this technique was that it was only limited to 10 minutes. At the same time, folks in Houston and Mayo Clinic and Jefferson were working on developing the heart-lung machine. So this technique was valid for almost a decade. And however, it was a turning point in the evolution of cardiac surgery and taught us how can we use hypothermia to our advantage. Another credit to Henry Swan is that he was the one who coined the term of alpha stat, and we'll talk more about it later on. But really, what brought us here was the seminal work by Dr. Greep at Mount Sinai almost 50 years ago. And he demonstrated that deep hypothermic circulatory arrest using the cardiopulmonary bypass machine could provide the brain protection and also protect the visceral organs from ischemic injury and provide the ischemic tolerance. And for subsequent decades, for many, many decades, actually, deep hypothermic circulatory arrest became the mainstay of strategy for brain protection. However, the limits of hypothermia were obvious when more data started to accumulate. It became very obvious that brain is still metabolically active. Imagine if we cool down someone's brain and body to 15 degrees Celsius. Brain is still metabolically active for 17%. And it was obvious that if we can stop the circulation safely at a 37 degrees Celsius for 5 minutes, the safe time for brain protection at 15 degrees Celsius was only 30 minutes. So this time limitation led to further interest. However, the group which adopted the deep hypothermic circulatory arrest as the only strategy, they demonstrated really outstanding outcomes, particularly coming from Yale with John Alftriardi's group. And one of the fellow who worked with me as a co-fellow, he demonstrated to me that when Dr. Alftriardis used to extubate his patient and post-op day 1, he asked them to spell his name backwards. So you could imagine that how hard to spell his name forward. So essentially, he was trying to demonstrate that these patients had outstanding neurological outcomes. The risk of stroke remained very low to 2% up to 50 minutes. And they noted that once the deep hypothermic circulatory arrest exceeds the time of 50 minutes, the risk of stroke was enormously high. All of these outcomes were great, but somehow cardiac surgeons became satisfied with this technique and it stalled the progress. This is the consensus on established by the ARCH study groups on definitions of hypothermia. You could see the definitions are very broad, but a few things I want to really highlight here that on the left, on your right column, you could see that in patients with deep hypothermia, even at the temperature of 20 degrees Celsius, brain is metabolically active in 75% of patients. There is no electrocerebral silence. And the brain metabolic activity is not linear. Once we rewarm the patient's brain or body from 15 to 20 degrees Celsius, the temperature, the metabolic activity increases 8%. But as you jump from 20 to 25 degrees Celsius, the metabolic activity increases to 13%. So brain is 37% active. So how can we protect the brain during these formidable procedures? That led to the interest of using the adjuncts. In 1990s, both retrograde and antegrade cerebral perfusion became popular. Can we add some other adjuncts by perfusing the brain in addition to deep hypothermia, directly instilling the blood into the cerebral arteries or going backwards through the veins? So there was a significant evolution of brain protection techniques, both from the cannulation and protection strategy standpoint over the next 50 years. The initial mainstay was femoral artery cannulation. Then for type A dissection, we started doing ascending aortic direct cannulation using modified Seldinger technique. Axillary and nominate arteries cannulation became very popular, and simultaneously we started exploring, while deep hypothermia is great, can we go to the warmer temperature? Can we go to the moderate hypothermia? Can we even warm the patient a little bit more and still protect the brain and body? So the concept of selective antegrade cerebral perfusion is not unknown. Dr. DeBakey earlier used right axillary artery for cannulation for his cardiopulmonary bypass pumps very early on in 1960s. But this technique was really popularized by Dr. Kuzui and subsequently Bechet from UK. And that most common techniques for brain protection was using a cerebral perfusion are either axillary cannulation or a nominate cannulation. These were popularized by work of Joe Savick at Cleveland Clinic and Dr. Casale's work at Baylor College of Medicine, Texas Heart Institute, where they demonstrated that sewing a graft to the axillary artery instead of directly cannulating the axillary artery is a much less morbid procedure, and equivalent outcomes can be achieved by nominate artery cannulation shown by Dr. Casale's group. Subsequently, one of my mentors, Dr. Lars Svensson at Cleveland Clinic, demonstrated that if you directly cannulate the axillary artery by sewing a side graft, you can actually minimize the risk of stroke in both patients needing complex cardiac surgery as well as hypothermic circulatory arrest. This is a technique of antegrade cerebral perfusion where we sew a graft to the axillary artery on the right side of the nominate artery and cool the patient to 28 degrees Celsius. We don't currently go to deep hypothermic circulatory arrest of 18 or 16 degrees Celsius anymore. Once the circulation is stopped, the brain perfusion is maintained at 10 to 15 ml per kilogram, and we aim for EEG silence by using additional propofol. Selective antegrade cerebral perfusion can also be moved to a bilateral antegrade cerebral perfusion if patient has a decrease in the nears on the other side, on the contralateral side, particularly those patients who don't have intact circle of Willis, and their brain perfusion decreases on the contralateral side. You can add another cannula. This is the editorial by Bachet. He said, I have one brain but two hemispheres, so please perfuse both adequately. So there was a rift between the unilateralist and bilateralist in the cardiac surgery in protecting the brain, but really outcomes there has been no major difference in the outcomes of brain protection using both either antegrade or bilateral cerebral perfusion, except in very long cases requiring total arch replacement. Now, what we know up to now, that deep hypothermic circulatory arrest was great. Hypothermia is fantastic. Can we go to the warmer temperature and avoid the morbidity of deep hypothermia? Dr. Casale's group looked into 200 patients who either underwent a deep hypothermia or moderate hypothermia. And what they demonstrated that the warmer temperatures were protective. Patient who had a moderate hypothermia, they had less in-hospital mortality and less risk of death. Subsequently, Emory group looked into 500 hemi-arch patients who underwent cardiac surgery at moderate hypothermia. They went even further bolder that they divided patients into mild and moderate hypothermia group, and this cohort included both emergent and elective procedures. What they looked into it that the cardiopulmonary bypass time was prolonged, particularly in patients with moderate hypothermia, just because it required a little bit more rewarming. However, there was no significant difference in the mortality or neurological outcomes in both groups on the propensity match analysis. Subsequently, they looked into their outcomes. How about type A dissection? It's established that for maybe hemi-arches, moderate hypothermia is great. Type A dissection are very critical procedures where you don't know what you are looking into as you cannulate and you start the circulatory arrest. So they evaluate their outcomes on moderate and deep hypothermia. And they noticed that in patients who underwent moderate hypothermia, they had better outcomes. Patients who had deep hypothermia, they had a higher risk of tracheostomy. And again, there was no difference in the adverse outcome of death, stroke, or transient neurological deficit, or renal replacement therapy in patients who had a moderate hypothermia. So now we established that moderate hypothermia is good for hemi-arches. Moderate hypothermia is probably good for type A dissection. How about more extensive procedures? How about total arch replacement? So this was the study by Arch Group, where it was a multinational study where they evaluated the outcomes in more than 3,000, cohort of 3,000 patients, and they had a propensity match analysis performed on 680 patients in each group. There was significant variety of circulatory arrest time, but when they looked into the perfusion time and deep hypothermic circulatory arrest time, there was no difference in the outcomes in respect to neurological outcomes, stroke, death, or renal replacement therapy. And looking into the variables for mortality and permanent neurological deficit, the temperature did not significantly impact the outcomes. So what that demonstrates is that probably the moderate hypothermia or warmer temperatures were good for not only hemi-arches, but also type A dissection and perhaps for total arch replacement. Well, one would say that, well, you have demonstrated that brain is protected very well. How about the lower body? The surrogate of the lower body protection when we induce circulatory arrest, actually there is no blood flow going to the body. What happens to the patients who have moderate hypothermia versus deep hypothermia. So these are the two studies done, one at Penn and other at Duke. And both studies were done at 10 years apart with the primary endpoint of renal failure based on the Rifle criteria. And what they noticed that the degree of hypothermia was not associated with acute kidney injury. The lower GFR, reduced ejection fraction, or longer cardiopulmonary bypass time were the primary risk factors for postoperative AKI. So at this point, we have concluded that probably integrated cerebral perfusion is a great strategy, but there is another group which I really thinks that retrograde cerebral perfusion is probably the ideal strategy to perfuse the brain. Why would retrograde cerebral perfusion work? You know, as all the students, residents, fellows here know, that coronary circulation and the IJ or the main large veins are the special structures where we don't have valves. And in cardiac surgery, we utilize both of these to our advantage. We inject the cardioplegia through the coronary sinus and induce the cardiac protection. Similarly, we use the right IJ or superior vena cava for retrograde cerebral perfusion. This is our strategy where for the retrograde cerebral perfusion, where you can see a cannula is on your right side. There's a venous cannula, and we are preparing for the complete aortic cannulation. Generally, retrograde cerebral perfusion, when it was introduced, it was combined with a deep hypothermic circulatory arrest. Why would retrograde cerebral perfusion work? You are injecting the blood into the veins, and you're trying to flush all the air and debris back. And you are also taking an opportunity of injecting the cold blood to the brain and causing topical hypothermia. When retrograde cerebral perfusion was introduced, it started to question the validity of deep hypothermic circulatory arrest. Do we really need warmer temperature? Do we need to cause deep hypothermia? This is our technique where we cannulate the superior vena cava and cool the patient down to 28 degrees Celsius. And we increase the pressure and flow the blood to the brain at the pressure of 30 to 50 millimeter mercury, which is slightly higher than usually described in the past. So retrograde group really was very popular among some of the groups, and it became really cultish to the extent that people who believed in RCP really believed in that, because they thought it was a simple procedure. You don't have to manipulate the brain arch branches, especially in the patients who have significant atherosclerosis. How are the outcomes of RCP? So this is the report by Lenny Girardi group, where they demonstrated that even up to 50 minutes, and they compared the patient who had a retrograde cerebral perfusion for 50 minutes or less or more than 50 minutes, and they demonstrated that there was no difference in outcomes in stroke, in death, and a transient neurological deficit in patient who had a RCP time of more or less than 50 minutes. So RCP is a relatively simple procedure, and moving forward, what should we do? What should we do in our practice? I will just show you a few videos to demonstrate our operative strategies. So this is the setup of RCP. Here our nurses are working closely with the perfusionist and passing the lines to de-air the RCP circuit. While we are preparing and residents are opening the chest, and you can wear 2 masks at that time to observe them. And in CT surgery room, it's never a dull moment. So this is our strategy. We wire the arterial line into 2. We have a direct cannulation on the red line on the left side of the patient, and then we have arterial line further wired into SVC or integrated cerebral perfusion, and being able to do the retrograde cerebral perfusion at the same time. This is an example of a hemi-arch replacement. We are snaring the superior vena cava. We're performing the David valve spinning root replacement. So the lower body circulation is completely stopped at this time. Brain is being perfused by retrograde cerebral perfusion. Strip of felt is being used. And this patient had Louis-Dietz syndrome, which is a aortopathy, and we used felt to further reinforce our suture line in this case. The procedures are generally fairly quick. It takes 10 to 12 minutes for us to conclude these operations. This is how it looked like at the end. The patient's heart is happy, the aorta is replaced, and the arch is replaced. This is a case of acute type A dissection. Patient presented to us with a significant, a very large aortic root aneurysm. We performed the central aortic cannulation. As you can see, that 3 rumels are demonstrating that we have dissected out all the arch branches. We are ready to centrally cannulate through the purse string. Here, this is the dissection of both innominate left common carotid and subclavian arteries, which have been exposed for bypass. And using modified Seldinger technique, we are doing the central aortic cannulation in type A dissection. This has become the mainstay and very popular strategy to cannulate the patients. Here we have bypassed both innominate and subclavian artery. We have a wire coming from femoral artery all the way into the arch, which is coming out, and we are advancing frozen elephant trunk. You can also see the dissected aorta in the root inferiorly. This is a frozen elephant trunk graft, which has all the branches to bypass the innominate, common carotid, and subclavian arteries. Here we are showing the anastomosis. And this is the end result where you can see that patient's root is replaced, aortic arch is replaced with the bypasses. It's never a dull moment in cardiac surgery operating room, but I have to say that this is a teamwork. So now we know that both strategies of RCP and ACP are great. Moderate hypothermia is probably a better approach. What's the contemporary data on these outcomes? This is a study done by Chad Hughes, where he looked into deep hypothermic circulatory arrest with retrograde cerebral perfusion or antegrade cerebral perfusion. And they noted that there was no difference in the transient neurological deficit, clinical stroke, or TIA in these patients. Outcomes were very similar. So really, when you use deep hypothermia, it doesn't matter which strategy you use. This is the paper published, written by one of our fellow, and we adopted axillary cannulation early on, but subsequently we moved on to innominate artery cannulation. And we wanted to study and examine if there's any difference in the outcomes if you use the axillary artery versus innominate. And what we noticed that it avoids axillary innominate cannulation, avoids an additional incision, and it decreases the need of blood transfusion, including platelets, red blood cells, and FFP. Also, the cardiopulmonary bypass times were shorter in patients who had innominate artery cannulation. So certainly there is some advantage to the showing a direct 10 millimeter graft to the innominate artery, perfusing the brain as well as body for the cardiopulmonary bypass. Emboldened by this, that we were showing a graft, we further studied into cannulation of the innominate artery, which is kind of a little bit bolder strategy, such that using the Seldinger technique through a purse string, you place a cannula of either 12 or 14 French and directly perfuse the brain. And we noticed that our cardiopulmonary bypass and circulatory arrest time was even shorter when we use this technology. So what is the current status of cardiothoracic surgeons? What are they doing in the real world? Unfortunately, 21% of cardiac surgeons even don't do circulatory arrest. And those who do, they are split. 23% of them use antegrade cerebral perfusion, and 19% use retrograde cerebral perfusion. This is the outcome from Japanese database, which also clearly taught us that both ACP and RCP are very equivalent in terms of the outcomes. But this study from Brad Leschnauer was really a study which was a game changer for us. It was a pilot study which looked into only 20 patients who were randomized into ACP versus RCP. And their primary endpoint was stroke, transient neurological deficit, or MRI-based confirmation of neurological injury. Both cohorts were very similar, and the neurocognitive outcomes in both cohorts were very similar as well. However, to our surprise, when this study was published, they noted that patients who had ACP, 100% of them reached the primary endpoint. So this study was a game changer and started to raise the question and challenged our current belief: is the moderate hypothermia with antegrade cerebral perfusion is as safe? And the challenges of cerebral protection techniques is because most of the studies rely on clinical outcomes. There is very little evaluation of outcomes on neurocognitive or MRI-based data. Dr. Swenson looked into 120 patients where he scanned and performed MRI on all of these patients and did the neurocognitive outcome analysis. They noticed that the clinical stroke was only less than 1%. However, 23% patient had neurological injury based on the MRI. This led to this Gard-Ice paper, which was one of the only randomized clinical trial in cardiac surgery world, looking at the brain protection. They randomized patient to deep hypothermia, low, moderate, and moderate hypothermia. And they noticed that the low, moderate, and deep hypothermia are probably equivalent. However, verbal memory deficit was significantly higher in patients with moderate hypothermia. So also, I think we have to be cognizant of the fact that there was a significant loss of brain gray matter, no matter what strategy you use, although the white matter was significantly preserved. So this, this temper our enthusiasm that hypothermic circulatory arrest is still completely not a safe procedure. How about the neuromonitoring? One of our fellow, Christian Ginchia, when he was in our lab, looked into the neuromonitoring advantages and how can we read through when we are monitoring the brain during circulatory arrest, because there were a significant number of patients who had neuromonitoring alerts, but they did not really have stroke. And the final message from this paper was that the negative predictive value of the neuromonitoring is 95%. What does that mean? It means that if you don't have any neuromonitoring alert, there is 95% chance that perhaps your patient does not have stroke. When you're talking to the patient's family at the end of surgery and there is no alert, you can say them with a 95% confidence that probably he would not have stroke. So we know Henry Swan's work, and based on that, the alpha stat and pH stat became the popular strategies. Nowadays, our current strategy is to use the pH stat early on when we are cooling the patient because it helps in the cerebral blood flow, and then we subsequently switch to alpha stat when we initiate the circulatory arrest and we rewarm the patients. So this is the current guidelines for both aortic aneurysm and type A dissection. They recommend that deep or moderate hypothermia should be combined with ACP and RCP. Now, in the interest of time, I will just jump to our last day paper where we looked into combination of ACP, RCP, or RCP or ACP alone. And these are the various cannulation strategies. We call it a Shaggy aorta protocol, where we initially start the RCP at the opening of circulatory arrest, and then if we exceed 10 minutes, we switch to ACP. We also measure the oxygen extraction in these patients, and we noticed that unlike previous belief where they demonstrated that there was no oxygen extraction in RCP patient, we noted that there was 93% median oxygen extraction in these patients who underwent retrograde cerebral perfusion. This paper was published by Anna Gergen as a first author by our group. And outcomes were really very similar between the Shaggy protocol versus integrated cerebral protection alone. And we challenged the traditional paradigm that probably brain can be perfused at a slightly higher pressure with adequate oxygenation. In summary, our operative approach for the neuroprotection encompass all three stages. We look into the preoperative stage, we look into the circle of Willis, we look into the stenosis of carotid arteries. Intraoperatively, we wash out all the embolus. And if our circulatory arrest time is more than 10 minutes, we switch to the integrated cerebral perfusion. When patient is admitted to the ICU, we wean the sedation very quickly, extubate them as early as possible, and perform the neuro check. If there is any concern for stroke, stroke alert is called. And if there's a large vessel occlusion, we work with the neurointerventional group. In the operating time, while we are inducing circulatory arrest, our anesthesia and perfusion are maintaining the oxygen delivery, optimizing the oxygen delivery and blood pressure, as well as preventing the anemia. In summary, some degree of hypothermia is a pillar for brain protection strategies. Hypothermia alone is good, but not good enough. You have to combine either with the retrograde or integrated cerebral perfusion. Retrograde cerebral perfusion work for the short circulatory arrest time is good for washout, for hemi-arch procedures. We generally use that. Today, I'm going to do a hemi-arch, and I will be using RCP on that patient. ACP is good for longer circulatory arrest times. When considering ACP and other studies, there is no single strategy which has so far proven to be superior, so there is need for clinical trials. I am grateful to all of my partners here, as well as the Aortic team, including Elizabeth Devine and Stephanie Ortiz, as well as CT surgery residents, fellows, perfusionists. And really, it takes a village to develop an aortic program and work on these protection strategies. Also, I'm grateful to my mentors who particularly nurtured my early interest in cardiac surgery and supported me over the years and showed me the path with their wisdom and guidance. Mentoring residents and fellows is very gratifying. It's great to see them doing well and reaching to their maximum potential. And thank you very much for your attention.
Yes.
Nice talk, Mohammed. It's great to see you guys doing all this really tricky work. Do you know our outcomes for stroke? And then what do you guys do in the middle of a case when neuromonitoring tells you, hey, I see a massive change on the brainwaves?
Yeah, that's a great question. I skipped on those slides actually. So our outcomes for stroke in patients with a hemi-arch is 1.3%. So our outcomes are really outstanding. Now, when we counsel our patient, we tell them based on our outcomes, not on national data. The outcomes are slightly, the incidence of stroke is slightly higher in patients who require total arch replacement, which is up to 5%, whereas total arch replacement performed as an urgent procedure in type A dissection could be as high as 9%. What was the second question?
What do you do when you have
when we have a neuromonitoring, certainly that was the impetus of that paper by Christian Ginshia was because when you get a neuromonitoring alert, in the middle of circulatory arrest, it actually creates a lot of noise, and you're trying to learn and listen through the noise. So what we do is we increase the brain perfusion. Generally, if we have a unilateralization, if there is one side of the brain has decreased perfusion, we sometimes use bilateral cerebral perfusion. We increase the flow initially from 10 to 15 ml per kilogram. If you're using ACP, if still there is no change, we'll add a cannula to the contralateral side and perfuse brain a little bit better, thinking that may help. When we are rewarming, we are actively watching the patients. We can add also the retrograde cerebral perfusion. If we are concerned for stroke, we can do another washout. But all these patients who have these high deficit changes in the neuromonitoring, sometimes it could be as subtle as compression of the nerves while patient is being tucked in and their ulnar nerve is really compressed, and it could give you a subtle signs of lack of neurological function. We try to get a CAT scan early on. And as I said earlier, out of the 24 patients who had neuromonitoring alerts, only 9 patients had real stroke. So essentially, learning through this is another art. And I think we are the only group which have published these outcomes, and subsequently Pittsburgh also looked into that, confirming our data that the negative predictive value is 95%. I think that is much more satisfactory information that if you have no sign of stroke, there's no alert, you are very confident that patient does not have a stroke for 95% of the times.
Great, thanks. It's after 8 o'clock, so we should break up so everybody can get to their day. Thanks very much.